Alliance event. My name is Doug White. I am a local rheumatologist, and it is my pleasure tonight to introduce our speaker. But before I do that, I want to make sure I thank the people that are responsible for making this available to everybody here tonight. And first off, I want to thank the staff at Celebrations on the River for this beautiful space and for a beautiful dinner, and thanks for allowing us to use their wonderful venue for putting this together. The other people I want to make sure I give credit to are Renee and Richard Chris, who put the evening together tonight and did a lot of work to make this all possible. So a round of applause. As I think most of you are aware, the evening is sponsored by the local Lupus Alliance. This is a patient-oriented organization founded by Richard, and it's a nonprofit organization that raises a lot of money for the benefit of patients in the area. And this isn't a fundraising event, obviously, but this is one of the things that we try to offer back to the community. The board of the local Lupus Alliance is here tonight, so feel free to reach out to them and interact with them and talk to them, especially if you have questions about the local Lupus Alliance. So without further ado, I want to introduce our speaker for the evening. It is an absolute pleasure for me to introduce a longtime friend and collaborator and fellow researcher in the lupus world. Dr. Kim started at the University of Pennsylvania, stayed in that same town to do his MD and PhD at Drexel, where he became a T-cell biologist. He then did his residency and eventually landed for his fellowship in rheumatology at Washington University in St. Louis. And that's where we met, and we were, of course, fast friends with a lot of similar background, especially in the research realm. At that point, from an immunology perspective, he broadened his horizons quite a bit and became a B-cell biologist, and then eventually started to solidify an interest in lupus, and is currently the founder and director of the Lupus Clinic at Barnes-Jewish Hospital, Washington University in St. Louis, which is an enormous enterprise and an enormous resource for lupus patients in the St. Louis region. He continues to do an enormous amount of basic science research, but has also expanded in that realm as well, and now is pursuing all kinds of other research endeavors that have to go well beyond immunology and trying to meet the patients where their actual needs are. And one of those projects is what he's going to talk about tonight, kind of getting us exposed to the breakdown in communication and the erosion of social support that happens when patients with lupus and with other chronic diseases try and interact with the healthcare system. So without further ado, Dr. Kim.
Well, thank you so much, Doug. I really want to also give my thanks to the local Lupus Alliance, especially to Richard and Renee for putting together an outstanding event. I was able to talk to most of you in the back row. I apologize to everyone else in the room. It's not that you're less important, I just started back there. So my mouth sometimes gets a little parched, and I'll have this beer next to me because, Wisconsin, right? So I want you guys to let me know, well, actually, a show of hands, who here has been diagnosed with lupus? Okay. Keep your hands up if you can. Who else here has an autoimmune disease or something exotic? Okay, it's about a third or almost half. How many are caregivers? Okay, and I know there's a ton of healthcare professionals also in the room. So just as a disclosure, I do work with a couple biotech and also pharmaceutical companies related to lupus research, and I also give some talks for some of the companies. None of them are related to any of the content that's going to be discussed tonight. A lot of the work that I'm going to describe tonight has really essentially been a grassroots effort. So one of the things that I did in 2013 when I started the Lupus Clinic was essentially had a tripartite mission. The first is to execute world-class research, not just good research, world-class research on lupus. The second was to establish a clinic, and our clinic has multidisciplinary care. We have a dermatologist, a nephrologist, obviously a rheumatologist, all in the same clinic. On top of that, we have a nutritionist, social worker, occupational therapist. We're working on adding additional services. Now, this has been a huge challenge for us because everything comes down to money, and these things cost money. WashU has not been particularly very helpful from this, but we've been able to gather resources and trim costs elsewhere to be able to provide these services. And I think for lupus patients, and true for many other chronic diseases, this is important for, it provides this holistic, team-based approach that allows us to be able to address every need that we perceive is important for patients with lupus. The third is we're doing a lot of community outreach with the local region of patients with lupus and caregivers, because we realize we need their support in order to make sure that the clinic operates efficiently. So Doug had mentioned that we do quite a bit of research, and most of my time is spent doing research. I'm actually only seeing patients a half day a week because the entire research enterprise takes a lot more time. And frankly, it's like running a small business. WashU just provides me a room, a bathroom to do stuff, food and water, oxygen, internet connection, but they don't give me a whole lot else. And this is actually one of the most confusing things about universities that the public doesn't truly understand, is that when we're a faculty person at a university, they just provide infrastructure. They don't provide very much else. We're supposed to come up with everything else. But if you're surrounded by talented people around you, you get to generate numerous different types of projects, right? One of them we're going to be talking about and highlighting tonight is going to be social support erosion in patients with lupus. But as you can see, we have numerous other programs. And I think one that I want to highlight, because this is going to be something we're going to be emphasizing in the second half of this year, is the relationship of poor sleep and lupus. A lot of patients with lupus, about 80% of our patients sleep like junk. And what's more interesting is that if you have poor sleep quality at visit 1, you're twice as likely to develop a flare at visit 2. So now we're going to go back into mice and disrupt their sleep. Mice can get lupus too. There are certain models to be able to understand more mechanistically and see whether or not therapies can be developed to enhance sleep as a treatment for lupus. It sounds wild, but I think our preliminary data suggests this could be possible, which probably means it's not going to be true. That's just the way research is, right? But at the same time, again, these are the things that we're thinking about. So let's get back to this, because this is the main focus of the talk tonight. So, we are in close proximity to Washington University in St. Louis undergraduate campuses across this huge park called Forest Park. It's about 2 miles wide. And we have a ton of pre-meds that are over at WashU. And so we get a lot of them coming over to our labs saying that, oh, I want to do research. And I say, oh, that's cute, because I'm not sure if you know what that means. And they're like, oh, well, you know what, I want to shadow you in your clinic, which was ultimately their original goal, right, is to get clinical experience. And so one of the most talented people I've ever met was this guy named Jarek Leung. And in between his freshman and sophomore year in the lab, he absolutely sucked. And he knew it, and he hated research. And so I said, in your sophomore year, first semester, just shadow me in my clinic. I was thinking he was going to be pre-med. What ended up happening was that he ended up not going to medical school. He basically said, I think medicine is junk. The second thing, though, is that after his third shadowing experience with me, I said, oh, you know what? This patient looks, is so much better. Their proteinuria, the protein in their urine, has gone down, almost gone now from a year ago. We've been able to decrease this woman's prednisone. We see they're stable on their current meds, and there's no apparent side effects that we can pick up. But he was, he's observant. He was really observant. He had seen this person with me before in his first visit. And then he had the balls to tell me this: I don't think your patients are getting any better, Al. How dare you? All right? As a sophomore in college. All right? But he was not wrong. All right? How many lupus patients here can commiserate with this statement that your rheumatologist says, you know what, you are feeling better, you are doing better, yet at the same time you're like, am I? Is that something the lupus patients here, and maybe even other patients with autoimmune diseases, feel? Right?
So he was an anthropology major. He really was interested, and he is actually, ironically, one of the most empathic people I've ever met, which is a prerequisite for being in the healthcare field, but he did not want to have to deal with that. He wanted to better understand this question about why is their quality of life different than like the laboratory results and the outputs that we typically use to measure lupus. So he wanted to better understand the experience of living with lupus. Jarek was amazingly talented, and several years later, we've been able to get this paper out. I'm going to have the QR code up on the screen at the very end. So I don't know if any of you guys are familiar with QR codes. This paper is available publicly. You can read this. And so what you can do at the end is just put your camera app on, point it at the screen with the QR code that's going to be at the end, and then you'll ask you to open up the link associated with that QR code. I promise you, I made the QR code. It's not spam. It'll go directly to the website, which has this paper, right? So you can read it on your own, right? This is his senior thesis work that we're able to convert into a research manuscript. Now, the findings I'm going to present you to tonight are not going to be new for most of you, right? You're going to be thinking, well, of course. The reason why this is new is because a lot of physicians don't understand this, all right? And so this is the reason why this work has become very important within the lupus world. So the research approach that was undertaken for this particular project was very different than the research I have done in the past. Typically, I go into the lab, we do experiments, and we repeat the experiments to make sure that the original observation is indeed true. All right, and then you can do statistics on it to be able to determine whether the differences you see between a treated group and an untreated group is actually potentially real. Here, with this type of approach, Jarek, because he was an anthropology major, did what we call a qualitative approach. He actually interviewed patients and recorded those interviews, transcribed them word by word, and these are hour-and-a-half interviews, right? Because he wanted to hear from the patient themselves without prompting of a survey or anything like that. What's going on in terms of how you live with lupus, what you find to be the biggest barrier in living with lupus. And they call this the phenomenological approach. It sounds like voodoo to me when you say that, but the reality is that ultimately you're trying to get an understanding from multiple people how they experience the same phenomenon, in this case, living with lupus. There's a semi-structured interview, so he only had 3 questions lined up for this hour-and-a-half interview, right? But they were open and broad enough that the patients that were interviewed just gave him every piece of information that he needed in order to make sure that what he was observing and hearing was, in fact, a real phenomenon. And they get this through this concept called saturation. It's not necessarily important for most of us, but for the researchers, this idea of saturation is when the idea gets repeated over and over and over again within the same interview, but also gets repeated over and over again between different people. Right? Once you're able to make sure that the patient says, I know I've mentioned this before, but this is an issue for me, and then you hear this again from other people, then this is something that's really important for the qualitative research field. And then there's this thing called open coding, where essentially multiple people, including myself, read through the transcripts and assigned different themes to them, right? And it's actually the themes that are ultimately the data points that we use to be able to build the story about how social support erosion leads to decreased quality of life. And that's the home run point that we're going to bring up tonight. So just to give you an idea about the sample, it's 10 interviews across 6 women. It's not that many, but remember, these are hour-and-a-half interviews, right? So this is really a lot of data from this type of approach. Yes, we do not have men involved in this, and this is going to be an issue downstream, and I'll bring this up later. There are 3 white, 3 African-American. In St. Louis, we have a prominent African-American population. About 70% of our patients are African-American. About 2/3 of those patients come from zip codes where the median salary is less than $23,000 a year. So we have a very socioeconomically disadvantaged population that also happens to be African-American, and this has probably important implications in terms of our data set, right? There are 20s to 40s, and then, if this will go, we made sure that the diagnosis was durable. Sometimes you get diagnosed with lupus, and then there's questions brought up later. I was talking to a lady in the back there about her experience that she was recently diagnosed with lupus, but there's some questions about, certainly within her own thoughts. And so this is something we wanted to make sure is that the diagnosis of lupus was made, and has remained solid. And then, 6 people isn't that much. So one of the things that I do within our lupus clinic is, because we have so many projects that are ongoing, we have an annual research symposia where only the patients and the caregivers are invited. And we present updates, but largely because it was their data that gave us the answers. So, the patients deserve to know what we found. But the second is that we also solicit ideas from them. We want to know, are we on the right direction? Are we asking the right questions? Are our results interesting to them, or is there something we're missing from the patient's point of view? More and more research is going to be more patient-driven in the future. I would say in clinical trials, for example, patient-reported outcomes are becoming a huge thing. They're going to be as important as whether or not your kidneys are better, right? Are your kidneys better, and do you feel better, right? Which I think many of you would argue is equally important. So within this, one of the sessions, we had 42 audience members that were available for this kind of fact-checking. In other words, we presented the data I'm going to present to you now, and we collected information from them qualitatively, in other words, through their verbal word, about whether or not they felt like this was a phenomenon they felt like was real, right? Or did we misinterpret something, right? So you can see how much what we call rigor we apply to this, right? So rigor is super, super important in research because it provides that durability to our findings. All right, so the key findings. There are 3 main issues that we found, and many of this is going to resonate to many of you. You're going to think, well, no shit, Al. All right, I know this. All right, you're not telling me anything new. Again, I'm going to reiterate. What you're going to hear is not going to be news to you, but it's news, unfortunately, to lupus physicians because we don't ask about these things. All right, that's what we're trying to say, is that we have a problem here. The first is that the symptoms are ambiguous and unpredictable. Many of you guys can resonate with that, and I'll give you examples of what that means in a second. The second is that there are communication challenges. I think many of you understand that part. And then the third is that there's a lack of validation. These are all related to one another, and again, I'll wrap all of this up at the end. So let's talk about the ambiguity, right? So I'm going to start going mobile here because it's really hard to see. So ambiguity pre-diagnosis. How many of you with lupus, how long did it take you guys to get diagnosed with lupus? Before, when you first started having symptoms and then the physician actually said, you have lupus. How many years? Just throw out some numbers out there for the people. 7 years. 11, holy. 6 months, 8 years. All right, so the Lupus Foundation America has data 2 years. All right, that's about an average about 5.5 years. All right, this causes problems. Imagine 11 years, right? Who said that? How did you feel during those 11 years?
Frustrated, like I was crazy. So every time I went in, they would tell me something else. It's low iron, it's low vitamin D, it's stress, it's night shift, it's mold, it's
frustrated.
in my mind.
Frustrated, confused. There's no answer, and every treatment that was done was not effective, right? So bottom line is that physicians could not explain the way patients felt, why they felt the way they did, right? So one of the interviews said they, the doctors, did check for lupus numerous times, but my ANA wasn't that off. Even my rheumatologist said that unless you do a specific type of test, it's not very reliable. I was passing out from fatigue when I got home. They, the physicians, had no idea what was wrong with me, right? I think what's really highlighted here is this bottom part. The patients feel like they were stuck in limbo, right? You felt like you were stuck in limbo, right? And this results in frustration, right? So we're not wrong. Excellent, all right? So I think the most fascinating part is even after the diagnosis of lupus was made, ambiguity remained. Yes, right? A lot of yeses here, right? And that's fascinating, right? You think, oh, I got a diagnosis. I'm going to go around you because I'm going to knock you down. I'm going to make sure that, that you have the diagnosis. I know what I need to treat you with, and we're going to get you better, right? But the bottom line is that this uncertainty persisted. So the quote that we found, again, this is just one example of many. I'm just showing you the one that probably best highlighted this. This patient said, lupus can go off at any time. I might walk today, but I may not be able to walk tomorrow. You just don't know. It's hit or miss. I don't know how I'll feel on any given day, so it's hard to plan. Your life is like minute by minute. All right, so this is profound because this uncertainty is, I might walk today, but I may not be able to walk tomorrow. Your life is like minute by minute. Uncertainty, because of the unpredictability of the symptoms, became a defining feature of experiencing lupus, of living with lupus, a defining feature. This was such a strong theme in our interviews. All right? And this is something I was actually a little bit surprised by, and I have to admit I was super embarrassed. I'd never even thought about this. So ambiguity, unpredictability, it happens for a long time before the diagnosis occurs and persists in a different way after the diagnosis, right? So let's switch to communication challenges. How many of you with lupus or any autoimmune disease feel like you're frustrated communicating what you have to anyone around you? Yeah, right? It's not surprising. So we're going to first focus on family and friends. So the difficulty to communicate the lupus experience was a common theme, particularly the unpredictability, right? That you may not be able to walk tomorrow. You explain that to someone else, they're like, how's that possible? You're walking today, right? That just, that's so frustrating. I may have felt 90% better yesterday, but I have no energy today. I tried to tell them, you think I'm blowing you off, but I'm not. Does this resonate with the patients here? Yeah. You think I'm blowing you off, but I'm not. So communication breakdowns leads to distrust, right? And this damages relationships. You can't rely on that caregiver anymore because they don't freaking understand what you're going through, right? I'm not saying it's the caregiver's fault either. We're gonna come back to this because I think the problem here too is that the caregivers sometimes also need tools to be able to provide support, right? And these tools just don't drop out of the sky, right? This is a challenging disease to live with, right? So the problem here is that the caregivers want to help, they can't provide that help. There's the two sides don't meet, and as a result, the frustration occurs. There's a lack of trust, and then the relationships are damaged. Now, what's even more embarrassing, and this is something I didn't really think about, but the interviews were very persistent about this, is that the communication with physicians is a major problem too. How many of you guys feel like you have a good relationship? And this is open to the entire room. How many of you guys, raise your hand, think you have a good relationship with your physician? Right? There's gonna be some, right? But it's a minority of the people in the room. I guess some of you may not see a physician, but whatever, right? But that's embarrassing, right? From our field. When our field is leveraging the fact that we have this knowledge and we're the only ones that can be able to interpret what you're saying or what your labs are telling us and then be able to provide expert care. So the problem here with communicating with physicians being equally difficult is really problematic to me. So the quote was, I have symptom A plus this other thing. The rheumatologist said, well, you're supposed to have symptom A, B, and C. It would be just better if the rheumatologists receive the information that they're getting, but most of them throw at me what they read. With lupus, everyone is not the same. This is a very complicated, loaded statement, right? I think, I'm gonna just focus on this part. It would be better if the rheumatologists receive the information that they're getting, but most of them throw at me what they read, right? This is a problem within our healthcare field in general, and I'm going to come back to this in a second, right? If you don't match what I know, then you must not have it. Yeah, that's offensive, right? So when the patient experience does not line with the physician's understanding of lupus, this is another communication gap that erodes trust in the physician, right? Lack of validation. So again, this occurs at two levels, family and friends, and also with other physicians, all right? Communication breakdown leads to a lack of affirmation and understanding by caregivers, And this can even lead to a lack of belief from the patient in their caregivers. And also vice versa, that the caregivers think that the patient is just saying it to get attention. How many of you guys have felt like you were in that situation, right? Throw your hands up high and proud, right? If you can, right? Oh dear, okay, a lot more hands. Everyone doesn't have the rash. I think if everyone has the rashes, so this is what happens in St. Louis, we pluralize a lot of things, then others would believe it. But everyone doesn't have them. Lupus attacks in different areas, in different moments. I don't really hang out with a lot of people. They just don't really believe it. That's sad, right? I don't really hang out with a lot of people. They really just don't believe it. Disbelief that the patient's symptoms are real, right? They're actually saying, patients saying, I'm suffering from pain, let's just say. And then someone who you trust and love says, no, you're not, right? How would they know? Because they don't have pain? So this here led to this disassociation with their caregiver. They actually don't talk anymore. And this was just a family member. Right? So it breaks relationships. This lack of validation extends to physicians also. This quote really offended me more from a professional point of view, all right, that this even occurred. I just break down sometimes. The rheumatologist asks me these asinine questions, but the answer I give is not good enough for my rheumatologist. It's not what my rheumatologist wants to hear. It's related to the earlier quote about communication, right? But even when the patient is eloquently describing what they have, and the physician understands what's going on, the physician just says, you know what, 90% of what you said I'm going to ignore because it just doesn't make any sense. I mean, what the hell? Right? You're the one with the disease, you guys are the ones that need to be treated, yet the physician has somehow made up in their mind that this is not important. The answer I give is not good enough for my rheumatologist, all right? Physician has told the patient isn't right. Oh, right? This lack of validation, and then coupled with the communication challenges, the patient ends up delegitimizing their own symptoms. In other words, the patient says, maybe it isn't important. How many of you guys have felt that way? Right? That's insane. So like I said, this quote really struck a very dark chord in me, and also to Jarek. Right? We were very, I was shocked to hear this, because Wash U is supposed to be this world-class medical center. At the same time, apparently we don't know how to communicate with our patients because we don't know how to listen. All right? And I think the main problem is that physician training is what we call archetypal, right? What is the average patient experiencing? And we assume the average means that's going to be the most common. For some diseases, that may be true. In lupus, we know this is not true. I was trained by Rick Brasington, who used to be at Marshfield some 20-some years ago. Now he's at Wash U. He was an important clinical mentor to Doug and I. He told us that lupus patients are like snowflakes. You will never find any two that have the identical symptoms or blood work, right? It is incredibly diverse, which puts challenges in terms of diagnosing, right? But at the same time, we have to recognize as caregivers, as healthcare providers, just everyone's going to have a different experience from the same disease because everyone's symptoms are different. But somehow it doesn't match up because of how we're trained. We're trained, again, what is the average patient experiencing? And when I teach this to medical students, now Wash U med students are quite bright, right? But they still have the same problem of being human. When they learn this, they want to know what is the thing I need to know for the test, and how do I recognize this in the real world? And I said, I don't freaking know, right? You take it every patient one at a time. You've tried to figure out, does their lab work match up with their clinical presentation? And that justifies then using some sort of medicine like prednisone, unfortunately, or other medicines to be able to make sure that these symptoms are better, right? But again, they want the average because it's just simpler to learn. Right? This is my biggest challenge when I teach medical students. It's very hard. All right. There are a lot of things, a lot of concepts here that I'm going to try to summarize in one slide. So we talked about communication challenges, right? And we talked about lack of validation, and these are linked to one another, right? If you have a hard time communicating how you feel to someone else, they're going to have a hard time understanding and trying to develop empathy for you. If they can't develop empathy, then they can't validate your experience, right? So, you know, we don't know exactly where this you know, what drives, what's the origin of, you know, which one's more serious? Is the communication challenges, lack of validation? It's probably a combination of both. The ambiguity and unpredictability, though, was a theme that we think is not only seen in almost, well, it was seen in every interview and every member that we did the fact-checking in. But we think that this is driving these two issues, right? That the ambiguity, the unpredictability, hard to describe what you have. It's hard to relay to them what it's like to live with a disease that's day by day when they don't experience it. That issue causes problems with both the communication challenges and the lack of validation. And for the patients with lupus, do you think this makes sense? Does this sound right to you guys? Because I would actually love to get feedback about what else do you think could be adding to this. You know, I'm oversimplifying this, but I'm curious from the patients what else you guys have in terms of ideas, or what other elements am I missing? All right. And so you guys can think about that. So ultimately, at the end of the day, Jarek's project was looking, though, at what causes decreased quality of life in patients with lupus. What is the main problem? Right? And I haven't even brought that up yet. Right? So one of the things that became very apparent once we started working with this outstanding professor at St. Louis University named Beth Baker, she has dedicated her entire career toward developing programs at the community level to help restore social support, to help make sure that there aren't differences in healthcare being provided for the poor versus the rich, or based off of race. And so when we ended up chatting with her, she's like, this fits squarely in with this concept called social support. And I said, what the hell is social support? All right. I think I understood it colloquially in a very informal sense, but I didn't know it from an academic in terms of the true definition. So I just want to give you an idea of what we are looking at here. I'm just going to put all of this out right now. So there are 4 different types of social support. Appraisal is the sense of belonging, or that you're being validated. Your experience is being validated. An example of this is that you attend a lupus support group and you feel like the people at that support group both understand you and your experience. And it is at a level that some others don't provide. Right? That would be an example of appraisal social support. And we know this does not happen in lupus. So we already know appraisal is eroded. The second is informational. So these are things where advice, suggestions, or information is provided in order for the patient to better their existence with lupus. You want to learn more about your lupus, your doctor is available to answer questions and provide knowledge, such as side effects of medicines, etc. All right? I'm going to go into some details of this later, but we know this is also eroded. I think a lot of it is because the information that is out there doesn't always necessarily answer your questions. Right? The two that we found that was not as prevalent in our patient lupus population was instrumental and emotional. So instrumental is tangible assistance, something physical, like getting a ride to see your physician. All right? So these are kind of like more physical type things. And then the last one, emotional, like the love, caring, or trust. You want to vent your frustrations about living with a chronic illness. Say your mom's present is able to listen, talk to your frustration. This is linked with appraisal, and we know this is somewhat eroded, but according to Beth, I'm not an expert in social support research. She is. She says that the appraisal is the main problem here, and secondarily, emotional goes away. So in her view, the main two domains that are eroded are going to be appraisal and informational. All right. So the importance of the fact that two pillars of social support are eroded in patients with lupus is critical because there is a ton of data saying that if you have eroded social support, your quality of life directly goes down. And there is a ton of data in lupus that if your quality of life goes down, your survival and the symptoms that you have from lupus, including side effects, gets worse. So quality of life improvement independently allows people to live longer with lupus. And on top of that, gives you a better quality of life, just in general. Right? So the impact of this is going to be a topic we're going to be addressing at the second half of the year. And we ended up focusing on medical adherence. And the reason why I did this is that Plaquenil, how many of you guys are on Plaquenil? All right. It's great because Plaquenil is probably the most important drug we have for lupus. If your blood levels, there's some data published from France that shows that if your blood level is over 1,000 nanograms per mil, there's about a 90% reduction in future flares. Right? No other medicine has that power, and no other medicine has been shown to actually improve survival in lupus. Plaquenil is the only one. But the problem is that 70% of our patients in our clinic have blood levels that are drastically low. We're not just talking a little bit off, right? Remember I said thousands kind of this cutoff? We're not talking about like 900, 800. We're talking like 400, 300, 200, undetectable. Okay? Now, I have high blood pressure. I was diagnosed in college. It's just my personality, I guess. All right? And I don't take my blood pressure medicines every day either. All right? So I get this, and I'm guilty. But we wanted to have a better understanding of whether or not we can extract information from these interviews that gave us an idea why taking medicines is challenging for patients with lupus as a whole. Remember, I said about 3/4 of our patients do not routinely take their medicines. So there are a couple quotes here. So this is another example of how physicians have validated a patient experience. They try and tell me how I feel. Ooh, that's really harsh too. Not only are you telling them information and they discount 90% of it, then they turn around, they meaning people potentially like me and Doug, unfortunately, and say, this is how you should feel. What the hell, right? Or, oh no, the drugs do not do that. It does it to me. The rheumatologist doesn't take the drug, I take the drug. So this quote actually was very interesting because it got me thinking about certain drugs that we use for rheumatology in general. So rheumatoid arthritis, for example, the most commonly prescribed drug is methotrexate, and it works, right? It's just a lot of people don't like it because it makes them feel kind of crummy, right? I didn't really know that until one of my patients this past January. I asked, oh, well, your arthritis is better. I was doing this, all right? I'm such an idiot. I was doing this, right? And they said, well, you're not taking the methotrexate. And because, we knew this data was there. And I was like, so what do you want me to do? He goes, take my methotrexate. And I was like, ooh. And I was like, wait a minute. Yet at the same time, I told this person earlier to take it, so I better man up and just take it. So I took a mini dose, only 4 tablets, 10 milligrams, and it made me feel like shit for a week, all right? Even with folic acid. So I've stopped prescribing it. All right? I may be an outlier, but this person who provided this data, this quote, is absolutely right. We don't take the medicines, you guys do. And so as a result, we should believe everything that you say, right? Oh, it makes me feel tired, but your arthritis is better. The patient should literally slap the physician in their face and say, you're not listening to me. I still feel like junk, right? So since patients are being told how to feel, this increases frustration and then saps the willingness to engage with their physician. This was actually something that I think makes sense from a human nature point of view. Sometimes I shut down when at the rheumatologist office, and after I tell you, the rheumatologist, how I feel, and you tell me that's wrong, I get frustrated. So this was a patient that ended up switching rheumatologists within our clinic because their original rheumatologist just would not believe what they were saying in terms of a side effect with the medicine. Right. And this is, I mean, Doug, this is super shameful for us. It's super shameful for us generally in the healthcare field. Like, how did we get to be like this? All right, so medical adherence fits somewhere in here. There's definitely a lack of validation that occurs that leads to medical adherence. And maybe medical adherence is the link between this lack of validation and social support and the quality of life, right? Because if you feel better, your quality of life also improves, right? And maybe if you feel better, because you're taking your meds, So again, I don't know. This is pure speculation on my part, but this is what we do in our business and research, right? The idea may be stupid, it may not be original, or it may be completely wrong, but the bottom line is that at least ideas are out there to be tested. So what are we going to do about this? I've been talking a lot about the problems, but we obviously have to try to solve it. So over the past couple months, we've been engaging with a couple groups that both in terms of patients, healthcare providers, and also nonprofits. So the nonprofit entity in the St. Louis area is the Lupus Foundation of America. And basically doing focus groups with them to better understand what else are we missing, what challenges do we need to also address, are there certain approaches that we don't know about that they do that we can incorporate into a potential solution for this, right? So I'm not going to go through all of this, but these are things that we've all discussed with these focus groups. And what emerged at the end of the day was that, okay, support groups are nice because it gives you person-to-person contact, you get to meet them, look at them in the eye. So what they teach you in public speaking is be disruptive, right? That's the reason why I'm walking all around, because it changes your focus. You use pauses. You intentionally stare someone down because everyone else is looking, right? It causes disruption and increases attention, so thanks. But the bottom line is that the support groups may not be effective because of the unpredictability of the disease, right? So we know that this is an on-demand society. I don't watch live TV anymore. Everything goes through Netflix, DirecTV Now, whatever, right? That's just the way I am. So we need to match that. Many people want their content on demand, right? So we need to have virtual support systems, whether it be a website or an app, right? So last night we had a discussion with the board of directors at LLA, and one of the things I couldn't really objectively answer was kind of like, how does this look like in a virtual manner, right? So I tried to hack up something that maybe addresses this, and I'm calling this the Lupus Toolkit, which is kind of a stupid name. We're actually working with someone, a patient of mine with lupus, who works in marketing to help design logos and actually a catchphrase that makes sense. But one of the things that we wanted to do was, okay, bottom line, we want to enhance the quality of life of those living with lupus. And one way we were thinking about doing this, and I would love to have comments from the audience, is since everyone's lupus is different, everyone doesn't need the same tools, right? And the first thing we wanted to focus on, and this is a 3-step program that's going to take us a few years to kick in. The first one was to be able to have patients with lupus learn how to cope with the lack of social support, right? Because actually filling in the social support is actually a pretty challenging process, right? But meanwhile, we want to make sure that any self-destructive behavior that's unintentionally being done by the patient ceases. So one way to do this is that we are going to have like an online assessment that essentially determines what needs you have. Is it informational support that you don't really understand what medicines you're on and what they're supposed to do or what side effects are occurring from them? And then, going down, in this case, I just chose down ambiguity management because this is a theme that we saw in everyone, all right? And that, there are tips that can help with that, communication, listening, all right? And then kind of at the end, there's also a way to be able to go directly to the clinician that is kind of on call for this or a health educator. But, something like this, an assessment, one of the questions that can be done is to say, over the last 3 months, I've been able to complete my everyday tasks. And so this is important because the unpredictability of the disease both prevents task initiation and also task finishing, right? So this is the reason why this question I chose, and let's say it's rarely, right? And if it's rarely, then one of the things that we could do then is pipe them into ambiguity management or coping skills, maybe both. Again, depends on how the entire survey is done. And then here within this, we can go through different things that can help patients learn how to deal with the ambiguity. Some of it's self-help. It doesn't directly address the ambiguity, but there is data to show that self-help, like say through nutrition, while it may not have any effect on lupus, the fact that the patient is empowered to do something better for themselves spills over in terms of how they manage adversity. Okay? So again, this is just an idea that I'm throwing out there. All right? And we don't know how this final project is going to look like quite yet. We're going to try to get a beta version ready by the fall. I'm going to wrap up with this and then one more slide. So very recently, the Duke Lupus Center published this paper, which I think succinctly outlines some of the problems that our patients were telling us. So remember I told you earlier, Jarek was troubled by the discordance of how I felt someone with lupus was feeling. I'm going to stare at you. Okay, we're done. And how the patient actually felt. So we were unaware that they were doing this research, and Duke has an outstanding lupus center. And what they basically found was that there are certain symptoms of lupus that does get better with lupus medicines. But there are a lot of symptoms that don't get better despite the fact that everything else does, all right? So they basically said, oh, we're gonna call this type 1 and type 2. We're probably the most boring creatures in the world, but whatever, be it as it may. Type 1 are the ones that respond to standard immunosuppression. So this is like rash, kidney involvement, arthritis. Type 2, I don't know if it's necessarily non-inflammatory, but the bottom line is we know that many of these type of symptoms, which, fatigue, diffuse pain, poor concentration or inability to maintain on a task, sleep disturbance, depression, brain fog, they typically do not respond to immunosuppression despite the fact that the kidneys may be 100% better. All right? And maybe this is the way for physicians to be able to categorize type 1 versus type 2 things. Now, again, it's all about the tools. And physicians right now, we don't have good tools quite yet to handle type 2. We have made the argument that it's poor sleep that's driving everything in type 2. Our epidemiologic data, so basically, these are data where we get surveys from patients and correlating their sleep quality to all these metrics down here, really shows a strong association between the quality of sleep that they have on a consistent basis and then the presence of those type 2 symptoms. All right, so we think the answer is enhancing sleep. How many of the lupus patients feel like you wake up refreshed consistently? Hold those hands up high. That's what I thought. That's what I thought. I'm glad no one lied. All right, so 80% of our lupus patients, like I said earlier, sleep like junk. Right? For those who don't have lupus, or a caregiver or healthcare provider, can you imagine if you only slept 1 hour a night for 3 nights in a row? That fourth morning, yeah, you're gonna be a raging bitch, right? It's going to be really hard to cope with any tasks that day, right? Now, many of our patients with lupus, they just don't sleep poorly for 3 nights in a row. Many of them have slept poorly for 10 years, 15 years. All right, and so this is the reason why we started the SLEEPS project, which stands for Systemic Lupus Erythematosus and Evaluation of Poor Sleep. Really clever, yeah, I know, thanks. So the bottom line is that I think type 2 in our minds is all related to sleep quality. It's not how long you sleep. You can sleep for 12 hours, but if you wake up unrefreshed, you had poor sleep quality. Just as a reminder, sleep is a learned behavior. It's not natural. Right? This is the reason why with children and kids, you have to get them on a schedule for sleeping, right? Because they have to learn. Now, the reason why it's so important for humans is humans are the only species on the planet that deliberately delay sleep. Right? And also, we kind of screw up our circadian rhythms because we have lights on at night. When it's dark outside, we still have lights on. So our body still thinks it's daytime. All right? So this is more pronounced, the issues of sleep quality in patients with lupus. All right? And so this is something we are also independently looking at, but we think it plays a role in the quality of life also. Okay. I want to open up the floor for a Q&A. All right, I want to hear a lot of thoughts from you guys. This is that QR code, all right? And if you can't, if it's not focusing, you can just come up a little bit closer to be able to get the entire QR code kind of filling up your screen. Again, use your camera app. You just shine it on the QR code. It should tell you that there's a link to open up. You click on it, and it gets you to that paper I brought up earlier. That is basically a more deeper dive, a deeper dive into what we talked about today. All right. I want to thank you for your attention. I think this is a really important point that I wanted to bring up, particularly for the healthcare professionals. The patients and caregivers living with lupus know this inside and out. But the reason why I feel like this is important is because the awareness of this issue, along with what Duke has done, needs to be translated into the physicians and healthcare providers, right? Because otherwise, nothing is going to change, right? So I want to thank you again. Let's open up the floor for some questions here.
I have other chronic conditions, and I have an excellent relationship with my primary physician. But recently I was seen in urgent care, dermatology, allergy and immunology, and I was totally discounted. What I presented as my symptoms, what I know are triggers, totally discounted. So I have trouble translating the information to people who are not familiar with me.
Thanks for sharing that. I think this also highlights the second thing that we're going to be looking into more deeply is going to be the emergency room setting in particular is a disaster zone for lupus patients. And so I talked about phase 1 of this project is trying to give patients coping skills to be able to learn with loss support. This phase 2 is giving tools to caregivers to provide social support, right? Because then that will help fix that access. But the bottom line is that that was deliberate on my part. That was my fault. But the third part is addressing physicians themselves. That's going to be the hardest one. That's the reason why it's number 3, because it's going to require a massive cultural change. Urgent care, ER, they interact with patients in a very superficial way, right? And I don't know, we have to engage them. We're going to try to do that at WashU. They may not want to participate, right? But that's data also, right? If they don't want to participate, we're going to publish that, right? So I don't have a clear answer for you. I think that's an important point, and we're going to eventually address that at some point. Yeah. Any other question, comment?
I don't have a question. I just wanted to comment then why do they have a choice not to participate?
I mean, I can't choose. I can't force anyone to do anything, right? I can't force people to go into lupus, right, or rheumatology. If they really want to do dermatology, they go into dermatology, right? And maybe sometimes, it's kind of like a smoker who does not want to quit. I don't want them in a cessation group because they're going to negatively influence the other people around them.
I guess I meant more in terms of providing continuing education to all of the physicians. I would assume that, maybe I'm wrong, but in most professions, when there's continuing education required, that you would expect that all parties would need to participate.
They can participate. Whether or not they learn anything is a different thing.
Correct.
Right? And that does require that motivation, that inspiration to want to do it.
Sure, I understand that.
Yeah, this is a dark part of her field. This is a super, super dark part of her field. It is.
I just wanted to say that if you doctor in Crosse, which is where I go, it takes an average of 6 months to see the rheumatologist because there is only one at Vincent Skin Scan. So the first time that I went, I had to drive all the way to Rochester, which I could get in within 2 weeks, which is inconvenient in the middle of winter when you don't want to drive an hour and a half to get somewhere. So how do you fix that? I even mentioned it actually to the nurse. I've mentioned it to the doctor. So why is there only one rheumatologist here?
It's a great question. So rheumatology in general, there's a nationwide shortage, nationwide, all right? And it reflects kind of the older philosophies that there's nothing we could do with our diseases. Yes, our diseases aren't curable, but they're certainly treatable now. And I think with the advent of these, what we call anti-TNF drugs, these biologics like Remicade, Enbrel, for rheumatoid arthritis, this has really made the field much more popular. Now, Doug and I were talking about this yesterday. Last year was the first year that we had to actually reject rheumatology trainees into fellowship programs. All right? In other words, we've saturated all of our training spots. That was the first year ever. All right? So there's clear interest by medical, trainees in rheumatology. That's really important. Right? It's going to take some time for that leg to fill in the void. Right? But nevertheless, I think there has been so much advance in terms of the treatment of autoimmune diseases that we're learning a lot more about each disease and how the immune system interacts with these medicines that we never knew before. We're getting more researchers involved, we're getting more clinicians involved. Again, they're gonna train and then they're gonna go out and practice, make mistakes, because it takes experience, right? But I think this is going to fill in. I don't know, Doug, do you have anything else to add to that?
I don't want to be Debbie Downer, but it's worse than a workforce shortage. It's also a maldistribution problem. So we do have saturated markets in the United States. There's few of them, but they're all in urban areas. In non-urban areas, proportionately less. And we live in one of those areas where there's an underrepresentation.
Yeah.
I have a question about Plaquenil.
Yeah.
So they say after 5 years, it can affect your eyes. What's the long term to take Plaquenil? Can you take it for 20 years or something? Or?
The question was about Plaquenil long-term exposure. The answer is yes, you can take it for 20 years. The better question is, what's my risk of having something bad happening at the 20-year period? So this is actually one of the projects I didn't highlight we call SLOPE, where so Plaquenil, you guys have raised your hands. You guys actually know the story of Plaquenil? It's an anti-malaria drug. How did it get used in lupus? Yeah, you're right. Someone screwed up. No, it's actually not that dark. So what happened was that in the 40s, anti-malarial drugs new derivatives were being made. And the one that called chloroquine, which was available, actually had an unacceptable rate of eye toxicity. What chloroquine does is it binds very tightly to a protein compound called melanin. We know melanin, it gives us our skin color, right? When we tan, we're increasing melanin in our skin. That's what makes our skin darker, right? And so for reasons we are not 100% sure, chloroquine binds really tightly and pretty aggressively to melanin. Now, the inside part of our eyes is completely melanin, right? That's when you look into pupils, it's totally black, right? It's a ton of melanin. And when the melanin in the eye gets bound to chloroquine, it can induce a toxic event that kills some of the cells and can lead to vision changes, worst case scenario, blindness. The rate of that, somewhere between 1 in 1,000 to maybe 1 in 100. Right, based off of published data. Okay? So, and it could be race related too, right? These studies were done all over the world. Now, how many of you guys who are on Plaquenil, I haven't finished the story. This is how I think. So they gave hydroxychloroquine, which binds less tight, it has a decreased tendency to bind to melanin, dramatically so, and was deemed to be safer, so they were testing it out on the soldiers going out for World War II. By pure serendipity and a very observant person or group of people, they realized that there was a fraction of those soldiers when they came back to the States while on hydroxychloroquine or Plaquenil, that their rash and arthritis was much better. They later realized these people had lupus. Additional studies were done later on that confirmed those initial observations, became FDA approved, I think in 1954 or 55, right? That's how long that drug's been around for. So going back to your question, the testing that we have now to screen for plaquenil toxicity, done by an ophthalmologist, you guys should be seeing your ophthalmologist probably every year, and essentially the testing they do, one of them is called optical coherence tomography, which is called OCT. Basically what it does is it scans the back of the eye non-invasively, right? It's not like they actually go into the eye. It scans the back of the eye, and what we're looking for is a thinning of the layer where the melanin is at. Right? If it's thin, that is a surrogate for damage. I'm going to use that word surrogate. It's been published that people who are on plaquenil have a rate of thinning at 8%. But the blindness rate still is about 0.1 to 1%. Okay? Now, what did I say earlier about my patients taking plaquenil? What percent is actually taking plaquenil where the doses are therapeutic? It's 30%. This is the reason why we're going to study this. We don't know what's going on. Okay? I think that because the rate of vision changes is so low, even after 20 years, which is a risk factor for vision changes, you're still at a risk, worst case scenario, 1 in 100. 99 out of 100 people will be fine. Right? It's pure numbers. Right? This is a theme I've been telling a lot of the trainees today over at Gunderson. Right? It's a numbers game. If you understand the numbers, then you can really evaluate risk. How many of you with lupus have been on rituximab? Anyone? One? So rituximab is associated with this irreversible deadly condition called progressive multifocal leukoencephalopathy caused by reactivation of something called the JC virus. You're like, oh shit. Well, let's chat about this. Informational support, right? That happens in rheumatoid arthritis patients, 1 in 32,000. 1 in 32,000. Would you still take it? Yeah, I don't know what 1 in 32,000 means. That means 31,999 out of 32,000 people have no problems with it in terms of this PML thing. Right? So I think the thing here is, I get that that the severity of an outcome is one thing. The frequency of the outcome is another thing. And I think as humans, we tend to confuse the two. Right? Yes, vision change is irreversible. Blindness is irreversible. But if it happens 1 in 100, and we have tools to pick it up early, where you actually don't notice it at all, to me, that is the reason why I feel like it's a very safe drug, and it remains the most important drug for lupus. So, to more directly answer your question, what happens if you take it for 20 years? Most likely nothing. You'll maintain benefit based off of lots of data. Remember, it got FDA approved in the mid-50s, so we have lots of data on this. Okay? Yes, I get the severity outcome. It can lead to blindness. But the probability of occurring is really low. Right? Worst case scenario, 1 in 100. That means if you lived 100 times, one of those 100 times you'll have vision change. If you think of it that way. You had to follow up.
So in your study that you have up here, do you address that question about the plaquenil and the eye problems?
Yeah, so this is something that should occur in every visit. The problem is that much like, how many are students in here? There are a couple, right? A couple. When you go to a lecture and you leave the room, can you give that lecture? Hell no, right? So this is what happens in doctors' offices. We assume everyone is going to listen to us and understand it just like that. That is so naive of us, especially when we told you that type 2 symptoms like cognitive dysfunction is a major problem in lupus. All right? We are part of that problem as physicians. All right, so that goes into that informational support that we're trying to put into this website, this app, right? So that, again, it's on demand. Right? We know that because you put the answer in that you are taking, say, plaquenil, right? You can always revisit that, because oftentimes, how many times do you have to study something before you remember it? Don't answer that. You guys, it's just like, oh my gosh. right? But again, it's the same thing with patients, learning about side effects, learning about the risk and benefit. Again, as physicians, we assume, because we're like, oh, well, okay, here's my plaque when we're talking about blah, 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 blah. And then you leave and you're like, what the hell just happened? But we assume that everything was comprehended, right? So every physician handles this in a different way. I was seeing Doug's clinic notes, and he's very good about making sure not only he has a lot of information that's given to the patient about medicines, what to expect and stuff like that. So again, you can always revisit that, right? But he's smart enough to put it into his note also, because it helps, I think, other providers too learn, right? You first, and then.
Thank you. So my question kind of is two parts, but one is connected to what you were just talking about. When I was hearing you were talking about ultimate goal, the ultimate goal for the patient is that quality of life. You mentioned med adherence, you mentioned other things that would help that patient. And so how much of your study is looking at behavioral perception and intrinsic motivation and extrinsic motivation, which then connects to your model, and you have the arrows going down from when you were talking about
Communication validation or ambiguity.
I think it's got to go both ways, because if you have poor communication or poor validation, it adds to the ambiguity, and so it's more circular or multidimensional.
So,
just a comment.
Okay, so that's actually a good point. So basically, once it starts, it feeds forward. We're seeing everything.
Correct,
right.
And you create a cycle. You create a cycle, I think, in there. If I'm looking at other chronic diseases that have exacerbations type things, I'm thinking that I'm seeing those same kinds of behaviors, but then what does the patient ultimately want? What motivates me to take my medication? What is that intrinsic, extrinsic? And unfortunately, I'm a nurse, and so as we train, we often just say, if I just teach you more and educate you more, you're going to do it. That's not the motivation necessarily.
Right.
So what is it? And what if I just don't agree with you?
So the agreement part is actually really important, and that's when, as physicians and healthcare providers, technically speaking, in this particular environment, we're offering you options. We're not offering mandates, right? And so a lot of times, we have a vigorous response to this. I'm going to answer your question.
Yeah, that's good.
Yeah, okay. So anyway, here.
I'm sorry, it's not a response. It's another, maybe a question. I have MS, and so almost all of the medications for MS have the concern about the JC virus and PML. So anyway, I have known people that were a drug called Tysabri, and it was extremely beneficial. I mean, it wasn't me, but I talked to people. They couldn't walk, and now they can walk. And then the neurologist has the warning and says, oh, well, you got the JC virus. Well, it seems to me if the person is that much better, maybe about the quality of life, the physician wanted to stop the medication, but the patient still wanted to take it. So, I mean, it's an ethical thing, but whose life is it?
That's a really good question. That is really good question. That's a really good question. That's my answer. I think,
It depends.
no, I think that's fascinating, right? It is a real ethical issue. The FDA, for example, they're protecting at the population level. The physician is protecting and treating at the individual level, right? And in this very litigious society that we have, obviously, there could be issues. I think that as long as the medical legal world, the concept of competency is ultimately the most important thing. Are you competent enough to understand the situation and make an educated decision? All right? So if competency is established and you want to continue this drug, then the answer would be, yeah, go ahead, right? I don't know how many physicians would be bold enough to do that. I think you bring up a very compelling argument, though, that it is very effective. So just as a FYI, tisabri is a drug that blocks how immune cells actually, as they travel through the bloodstream, you have to think, they're going through the bloodstream really fast, right? Our blood pressure is actually quite high, but at some point they have to stop and get to the inflamed organ. How do they do that, right? So there are breaks that we call adhesion molecules, right? And what tisabri does is it blocks these adhesion molecules from working. So the immune cell that's going to drive an MS flare, for example, just keeps trucking through and doesn't get into the brain, right? But that seems to be important, though, for controlling JC virus, right? I think this is a great question. I think it's a great question. I think I'm in favor of you, but that's N of 1 for me. You think you'll find a lot of physicians that are going to be like, oh, you don't, I mean, I don't think you understand the risk. That's lack of validation in my mind, right? Okay, I totally skipped you. Here.
You can go with it.
No, you go first.
My question is just with validation, like maybe in your study or maybe something you may study in the future, is there any sort of attachment of more weight to a validation from a medical provider as opposed to a social network or family member or caregiver?
So that's a great question. So in the social support world, there are formal and informal sources of support. And so informal is going to be like social support groups, caregivers, and formal is going to be from healthcare providers in this specific case. Which one is more important? I think that becomes individually based, right? There could be some people that have partial erosion only because the relationship with the physician isn't great, or the relationship with the physician is really good, but it's with caregivers, right? So then I think that's where the individualistic component may be important. That's what I would speculate. It's a good question, though. I don't know which one ends up being more important as a whole, but I do think it's highly individualistic.
Sure.
Yeah. Anyone else? No, I'm joking. Here.
Hi.
Hi.
So I have rheumatoid arthritis, and it took a little while to get a diagnosis. My primary care doc tested me for Lyme disease, and it was negative, and just figured I had some post-viral syndrome. And eventually I went to see a sports medicine doc, and when I told them it just hurt everywhere, they got me in to see a rheumatologist the next day. So my question for you is, how much of that really long period that it seems to take people to get diagnosed, how much of that is due to not getting referred by a primary care doc, and how much of it is related to the disease process itself and how long it takes for biomarkers to show up?
That's an excellent question. So access is one thing, and Doug had mentioned this earlier. For me, because I only see patients a half day a week, my list is about 7 months right now. Right? But again, if I saw more patients, I can't get this work done. Right? This is the problem that we have, at least in the academic system. Remember, we're little LLCs. Right? We're like a kiosk at the mall. The mall's not responsible, and they're not going to help me. They're just giving me space. I'm responsible for everything else. Right? And that's the challenge about academic research that some of you guys can certainly commiserate over. So that could be part of it. I think part of it, though, too, is the biology of the disease itself. Usually the symptoms that initially come out are so, they are lupus, but they're too non-specific. We brought the example up at lunchtime at Gunderson about how some of the symptoms could be fatigue and joint pain. Right? Lupus would be like number 1,000 on the list in terms of common things. Right? So if you're going to work through that, sequentially, and if you made the guess that it was going to be lupus right off the bat, then that's playing cowboy. That would be hard to justify, right? In my mind, even though later on they proved to be right. So sometimes the disease, and again, we're working on trying to find improved biomarkers, improved labs to detect lupus and also monitor disease as it goes up and down. But until we can confirm a lot of some of our preliminary findings, what ends up happening is that the disease just evolves on its own because it's being untreated, say 11 years. Then something more specific comes up, all right? It's, to me, when that more specific, based off of 2019 standards, the time between the primary care physician or their, whatever their primary care provider is, to rheumatologist, I agree at that point then, that needs to be triggered. There's a national effort to try to get primary care providers to better recognize lupus earlier. And I don't understand that campaign. I get the campaign's purpose, I just don't know how can you do that when our labs aren't good enough to be able to do that. And the symptoms sometimes have to just evolve to something more severe, unfortunately, before we are like, oh, I'm going to now take the risk of giving you prednisone, which is not a trivial decision, right?
With MS, now they say the first episode or exacerbation is a clinically isolated syndrome, or something like that. So they don't immediately say, boom, you got this. Is that similar to other autoimmune conditions like lupus?
Yeah, so that's another good question. So again, to the trainees, all of the rheumatologic conditions are clinically based, right? We actually don't have, certainly diagnostic lab tests, for many of our diseases. All right, so in other words, it's just like the example of psychiatry I think I gave earlier, right? There's no lab test for schizophrenia, there's no lab test for anxiety, there's no lab test for depression or bipolar, right? Those are clinically derived syndromes. In other words, it depends on what the patient presents with, coupled with maybe some labs and some other things that we see, maybe a rash that we can characterize. All right, so because of that, it partially depends on the experience of the physician, right? Because the labs are easy to interpret. They give us ranges. We know what normal versus abnormal is. Kids would know that, right? And you don't need a physician to tell you that, right? It's the other parts, the clinical aspects. And I think one of the things that we're starting to see as there have been better imaging and better labs for diseases in general is that some of our trainees are coming out without the clinical skills required to really diagnose rheumatologic conditions accurately. We're seeing this more on the resident level, and I get that those people probably aren't going to go to rheumatology because they're like, oh, it's going to stress a skill set that I don't have. Right? A lot of the conditions right now, like a heart attack, right? We have EKGs and then you have blood tests like troponins that tend to be very specific, right? So you can even have a silent heart attack and have abnormalities in your EKG that are new and an increase in the troponin in the blood, and I'll diagnose you with a heart attack even though I'm not a cardiologist. Right? So that can be that simple. We don't have anything close to that in the rheumatologic conditions. MS is similar. It is a clinical diagnosis, very old school in that sense. But again, medicine has evolved, fortunately, for the other diseases, where there is a lot of precision and accuracy to tests. We have to catch up. You first, then you.
This is probably a simplistic question for you, but I'm wondering if you have mild symptoms in terms of when you experience severe fatigue, and
You call that mild?
No, but what I mean is this: when it tells lupus affects could affect any of these systems in your body. Do you always see lupus patients progressing toward damage to the brain or the immune system or the heart? Or can you get through life just sort of at a certain level?
It's probably B. All right, so most of the damage in rheumatoid arthritis, lupus, multiple sclerosis usually occurs in the first 3-4 years, right? And this is even if you're not taking medicines, all right? And this is after diagnosis. So remember, in lupus, you already have that 5.5-year lag. And then, so if you're on medicines that are effective, that time shrinks. Generally speaking, autoimmune diseases don't recruit additional symptoms as you get older. Rarely it does, and usually the people that are not responding to medicines. But again, that's still a minority of people. So generally, when they present, say, in the hospital, and they get diagnosed with lupus, I can pretty much guarantee with a fair amount of certainty, like 90% certainty, that that's all they're going to have the rest of their lives. right? And then our goal as a physician is to say, this is going to be the worst day you're going to have with this disease. We're going to try to get you so that only thing that reminds you of the disease is taking the medicines. Of course, that path is really hard, but that's a good question.
Do you, at your university, are you studying at all diet and how that plays into people with lupus?
Diet. So the answer is I am not, because I find it a really hard field. So diet probably has the most profound impact on what we call the microbiota. How many of you guys heard that term? Right? You have about 2 to 4 times as many bacteria in your gut than you have cells in your body. And we often think that the bacteria that are there, which actually interacts with the nutrients that you eat from your food and produce compounds that your body responds to, is the single most important hormonal organ in your body. More important than thyroid, more important than your adrenal cortex, all these things. All right? Some of this work was pioneered at WashU. There's this guy named Jeffrey Gordon, who was the first to look at this in humans. And the reason why I'm saying he might win the Nobel Prize is that I think there's a lot of increasing data suggesting relationships with certain health statuses. For example, the most recent work that he did that was really, I found compelling, was that he wanted to understand why malnourished children, when they were given replenishing diets, still lag behind the growth curves of healthy children. And what he found out was that if you did a fecal transplant from the healthy children into the malnourished children and then gave them the same diet, they caught up. Right? I think that's a beautiful example of the potential. The problem is that while in mice we can definitely show a lot of relationship, in humans there's tremendous diversity of the type of bacteria that we have. And that opens up the possibility that what may be healthy for me may not be healthy for you also. Right? It's not that simple. Of course, there's all these details that we have to uncover. So diet, in my mind, manifests almost, at least the popular way of thinking about it, pretty much through the gut bacteria. Now, more generally in terms of nutrition, et cetera, it's even less clear. There are claims of anti-inflammatory diets. All right? So curcumin, for example, which is 3% of turmeric, all right, has been shown in rats particularly to be anti-inflammatory. The problem is how much you have to give. Right? So in rats, what they did was they gave something like 50 milligrams per kilogram of body weight to the rat. And that's curcumin. And it was given, I believe, IV. So if you wanted to give that to a 220-pound man who's going to be 100 kilograms, all right, that would be 5 grams of curcumin. But remember, that's only 3% of turmeric. Right? So you have to, and this is daily. And you have to add on the fact that if you're going to give turmeric, you only absorb about like 30 to 40% of it because it's very, you can overload the transporters. So you don't absorb all of the curcumin either. So you have to account for that. You'd be glowing orange, probably. Right? Not to speak what color your stool's going to be either. Right? So I think, though, in my mind, that's an important proof of concept that these can manipulate inflammatory pathways. Is it feasible? No. But it is something that maybe a drug company could target pathways that are involved. That could be one way to apply it. All right. So I think in terms of like the healthy lupus, healthy MS, healthy RA, healthy whatever diet, I think this is the reason why our recommendations are so kind of bland, right? Avoid a lot of red meat. I think a lot of red saturated fats are, they really are not wonderful in general, all right? Trying to, stick to unprocessed foods, so greens and, things that aren't necessarily kind of prepackaged for you. Limiting caloric intake to what you only need, right? It's kind of very simple things that are hard to do, yeah.
Have you done any studies on the effect of gender bias on people.
Gender bias.
I only say that because I have fibromyalgia,
Mm-hmm.
and I did not get help until I saw a female. And it had not occurred to me before that.
That's interesting, and that's unfortunate. In lupus, I don't know off the top of my head, because 90% of patients with lupus are female. I would say for these type 2 symptoms, the more what we call subjective, right? There's no lab test for pain, for example, right? So that's where some validation problems also occur, right? That is probably, I'm sure there's a ton of gender bias research on that. I'm not aware of it. It makes a lot of sense though, just because of cultural things, all right? And also how, maybe men engage with their symptoms also, which complicates things. Last night we were talking about the board meeting about how there are cases where, there are gonna be men that just don't want help, right? They kind of just live with it because that's kind of the way things are for men, all right? Is that right or wrong? It doesn't really matter because that's culture, right? We just have to learn how to work around that to find a solution for these people. We just have not found that path yet. So I would imagine there could be some, maybe gender bias against men in lupus, right? That's it? No, thank you guys so much. I hope we were able to address a lot of things, confirm a lot of what you guys were thinking for the healthcare providers, kind of open up your mind, particularly the students. You're going to run into situations in the hospital where they're going to, you're going to run to someone super cynical. Just deal with it. Don't lose your enthusiasm for making sure that empathic behavior is the a priori characteristic that you associate with healthcare and interacting with patients. All right, don't ever lose that because this is the reason why this shit happens. All right, thank you guys so much.